Well, welcome everybody. I'd like to thank the Utah Dental Association and the California Society of Periodontists, specifically Dr. Rich Gao, for the invitation to present information on the 2017 classification of periodontitis, and we'll focus on periodontitis. So the title of today's course is What's New and Why Do I Need to Use This New Classification? I'm David Okano. I am teaching at the University of Utah School of Dentistry, and I am the section head of periodontics at this time. So I have been at the School of Dentistry for the last 5 years. I came when the school opened on the clinic floor, and it's been a great transition for me to now be at the School of Dentistry teaching periodontics after a long career in my native state of Wyoming. So I'd like to share information regarding the new 2017 classification of periodontal and peri-implant diseases and conditions. And today, I wish to focus only on periodontitis. A world workshop was formed in 2017 to provide the newest classification on periodontal diseases, the first one since 1999, in fact. There are a number of other conditions that were described as a result of that conference. And particularly, we now have definitions for the peri-implant diseases of peri-implant mucositis, peri-implantitis, but today's focus will be specifically on periodontitis. Now, with the new classification developed in 2017, it reflects what's understood today, but we can modify and make enhancements as we learn more in the future. For 1999, the classifications did not change for an 18-year period of time, but with 2017, as we learn more, as the situation evolves over time, we'll be able to update the information. So that's why I want to emphasize we are constantly revisiting this, revising this. The American Academy of Periodontology has a task force to review where we are and make adjustments in the classifications. But we all recognize that as we teach this, it will take a little bit of time to get this integrated into everyday practice. And my goal is to introduce the newer concepts regarding how we now classify periodontitis. So what's particularly important to understand is that we are correlating a lot of the periodontitis classification with medical conditions. For example, we'll talk about stage 1, 2, 3, and 4 periodontitis, which corresponds to the prior slight chronic periodontitis, moderate chronic periodontitis, and severe chronic periodontitis. But I want to emphasize we now call it simply stage 1 through 4, and that is because this correlates a lot with medical conditions of chronic nature. For example, cancer is staged as stage 1 through 4. Stage 1 being the earlier stages, the more easily treatable and improved prognosis, all the way to stage 4, which would be considered terminal cancer. And our stage 4 periodontitis is sometimes considered a terminal periodontitis condition. So as you move to the 2017 classification, this is going to require a total alteration in your thinking process. It's a paradigm shift. So we need to move to a new environment, get out of the normal fishbowl that you've been, jump into a whole new environment, and then you'll be able to make a successful transition to the 2017 classification. So what's new, what's different about the 2017 classification? First of all, every individual is unique, and all of the practitioners, the dentists, the dental hygienists, we all know that every individual has a unique susceptibility to periodontitis. So now we can consider the uniqueness of each individual as we evaluate their periodontal condition. And the biggest item to focus upon with 2017 is the risk. Everybody has a different risk for periodontitis. So now we can place patients at varying risks for periodontitis into different groups, and our treatment plans can be formulated based upon the risk along with their maintenance intervals. So management through treatment and maintenance is very, very important as we move to the 2017 classification. Now, as I mentioned before, we now call periodontitis in terms of staging. The stage relates to the severity, how severe the destruction may be, which is similar to the 1999 classification. But now we're also considering the extent of periodontitis, and in particular, how complex the periodontitis condition may be, because that's very important as we formulate treatment plans. We also introduced with the new classification a concept called grading. Grading relates to the future risk and the progression, how fast the disease has progressed over time. We all know of younger individuals who have substantial periodontal loss, and therefore they have greater risk, and we can identify those individuals through the grading concept. And now we are considering the systemic effects upon periodontitis, specifically the effect of smoking and diabetes upon the periodontal attachment, and those folks have greater risk for continued progression of their attachment loss. In other words, they will be at greater risk for ongoing bone loss. So I want to introduce this table that has been produced by the American Academy of Periodontology. This is the staging. There are different components. We'll go over each component as we review cases that fall into the stage 1, stage 2, stage 3, stage 4. But for now, understand that the staging depends on multiple factors. How much clinical attachment loss has occurred? With this classification, we're also looking at how much bone loss has occurred radiographically. So this is something new that's been introduced to the 2017 classification, is we're looking at the radiographic bone loss and the pattern of bone loss. We're now looking at patients who might lose teeth due to periodontitis, because if they have lost teeth due to periodontitis, they'll be at greater risk for more loss. And we're looking at different complexities, that specifically the type of bone loss, horizontal bone loss versus vertical bone loss noted in the stage 3, 4, furcation involvement of grade 2 or 3 with stage 3 or 4, and definitely the stage 4, as I mentioned earlier, often considered to be the terminal dentition. So if I can bring one point here, with stage 3, our students have had little challenge differentiating stage 3 or 4. The simple thought is that with stage 3, you might lose a tooth. With stage 4, you might lose an entire dentition. In other words, a terminal condition for their periodontitis. We at the University of Utah have added this red line because this is a differentiating point. And I will say that Dr. Kenneth Kornman, a co-author of this paper, has stated that 70% of our patients will be either stage 1 or 2, the slight or moderate periodontitis, and 30% will be in the severe category of periodontitis. As you begin treatment for these conditions, everybody would benefit from phase 1 periodontal therapy, which includes non-surgical scaling and root planing. Non-surgical scaling and root planing is a great place to get started for any periodontitis patient. However, the red line denotes that particularly for our students with a severe periodontitis patient, you cannot expect non-surgical periodontal therapy to control the periodontitis and maintain attachment. Phase 2 periodontal surgery is indicated for patients in stage 3 and stage 4 periodontitis. So moving forward with the general concepts of grading, grading indicates how fast the attachment loss may be progressing. In other words, a slow rate associated with grade A. The more rapid rate of destruction occurs with grade C. Specifically, if you look at your patients over time, the grade A would be patients that are maintaining very well. They're not losing any attachment. In other words, there's no bone loss over 5 years. If you look back over the course of 5 years and they're starting to lose a little bit, but less than 2 millimeters, it would be grade B. And those rapidly progressive patients, these are the individuals that have patterns of bone loss that suggest rapid progression and are early onset of their disease. Those would be the grade C individuals. And if you don't have records, or if you have a new patient to your office, you can look at the indirect evidence, and this is a ratio of how much percent bone loss do you see radiographically divided by their age, and you come up with ratios. We'll go over examples of how that ratio is calculated and how you can use that to assign your patient to an appropriate grade. Now, risk factors of smoking and diabetes have been introduced. With grade A, a grade A patient would be a non-smoker who doesn't have diabetes. B would be smoking less than 10 cigarettes per day, and an A1C less than 7. But the more rapid destruction, the higher risk periodontitis patient would be a smoker of more than 10 cigarettes per day and an A1C more than 7. I must emphasize through all of the presentation that the worst area determines the stage and the grade. For example, you may have a patient, and we quite often see this with the patients that were formerly classified as aggressive periodontitis, they may have a substantial amount of attachment loss. They don't have a lot of biofilm deposits. Not a lot of plaque is noted in these individuals, and they may not have any systemic considerations. They're perfectly healthy, yet they lose a lot of disease. So even though an individual may not smoke, they may not have any diabetic considerations, they are losing attachment very, very rapidly, and they would then be classified in the worst category, which would be grade C in that particular situation. So a little more definition for the stages. Stage 1 was formerly known as slight periodontitis. For example, the 1999 classification may have called it a generalized slight chronic periodontitis with 1 to 2 millimeters of clinical attachment loss. Previous synonyms for slight would be early, mild, incipient, or beginning. Stage 2 was formerly known as moderate periodontitis. For example, 1999 would have been a generalized moderate chronic periodontitis, which would indicate 3 to 4 millimeters of attachment loss. The attachment is moving a little further apically on the tooth and progressing. Now, stage 3 and 4 were formerly known as severe periodontitis. A previous 1999 diagnosis would have been a generalized severe chronic periodontitis. Well, now for those patients who have severe periodontal destruction, we simply call it stage 3 or stage 4 with a corresponding attachment loss more than 5 millimeters. So as I mentioned before, stage 3 would be associated with a severe periodontitis in which a patient might be at risk for tooth loss. Stage 4 is much more complex, and you may lose the entire dentition as a result of the severity of periodontitis. We'll go into these in a little bit greater depth here. So again, think about slight, moderate, and severe periodontitis. I'll go to a slide in just a moment to talk about the radiographic bone loss that is new with this classification. And we still carry over a bit of the 1999. If you have less than 30% of teeth involved, it would be considered a localized stage 1 or a localized stage 2 periodontitis. But once you get more than 30%, you would call it a generalized stage 1 or a generalized stage 2, 3, or 4. Also, we retain a little bit in terms of a descriptor of the molar incisor pattern. Many of you may be familiar with the previous term of localized juvenile periodontitis, which became a localized aggressive periodontitis. Now it would be considered a localized stage 3 periodontitis. So for those previous aggressive periodontitis conditions, we still consider it a localized with a molar incisor pattern, for example, from the previous localized juvenile periodontitis, localized aggressive periodontitis. We'll go into these a little more and with corresponding cases. So this is a point I want to emphasize with today's presentation, in that we're looking at how much bone loss occurs. Now, if you've lost bone in the first 15% of the root, then that would be associated with a stage 1 periodontitis. 15% to 33% would be a stage 2. And once you get bone loss to the middle 1/3 of the tooth or beyond toward the apex, it becomes a stage 3 or stage 4 periodontitis. And I want to make the point that the new classification system uses a number of parameters, and you cannot hang your hat solely on one parameter. For example, in this short root, If you had about 3 millimeters of attachment loss on this short root, you're already into the middle 1/3 of the radiographic remaining bone. So with that in mind, 3 millimeters of attachment loss here is pretty substantial. 3 millimeters on the root here is not. We still have quite a bit left. 3 millimeters lost to this point puts this tooth at significant risk for continued loss of attachment and ultimately loss of the tooth. So think about the ladder as demonstrated on this radiograph. Divide the root into 1/3, and this helps you evaluate where the bone level might be radiographically to place the patient into an appropriate stage, because again, that relates to the risk of continued damage and eventual loss of a tooth. So one thing, and I apologize for emphasizing this 3 times, but this is the carryover slide from my school. We constantly emphasize to the student, the stage is now based upon the worst site of attachment loss. I emphasize that 3 times. So the worst site is what will determine your stage. With the former 1999 classification system, we could have a diagnosis of a generalized slight chronic periodontitis with a localized severe periodontitis of numbers 14 and 15. Now with 2017, we are assigning only one stage. So what I just mentioned becomes a generalized stage 3 periodontitis, generalized because there's a generalized slight periodontitis destruction noted, but the worst area of the severe periodontitis is what determines the stage. So always think worst case scenario for both the stage and the grade as you determine the appropriate stage and grade for your patient. Now, again, I went over the grading. We talked about how fast the destruction occurred. We talked about the ratio, which we'll demonstrate through examples in a little bit, and the systemic conditions. So the grading is what's very new and unique and to be applied with our new classification, and especially allows us an opportunity to place patients in different categories so as to identify the patients at much greater risk for continued destruction and progression of their periodontitis condition. So a couple other comments about staging and grading. The stage of the disease usually remains the same for the duration of an individual's life. Once you've lost the periodontal attachment, for the most part, you're not going to get it back. However, an exception to this rule would be a case of a patient who has a stage 3 periodontitis lesion with vertical bone loss more than 3 millimeters. If we had the opportunity to treat that vertical defect with regenerative periodontal therapies, and we no longer have the vertical defect, or it is no longer as deep as 3 millimeters, that stage 3 could be improved to a stage 2. So there are a few situations where we might be able to improve a stage, but it usually will remain the same or could conceivably get worse as the patient's periodontitis progresses over their lifetime. Now, grading may change over the course of a lifetime. It may worsen. For example, a patient who develops diabetes becomes at greater risk for periodontitis. So a patient may go from a grade A to a grade B or even a grade C if it's not well controlled. Now, conversely, your grade could change and actually improve over time. For example, the patient who quit smoking, patient that smoked 8 cigarettes a day, no longer smokes. Well, you could change that grade to a grade A from a grade B. Although I would be hesitant to change the grade for perhaps up to 5 years, because we know the effects of smoking upon the body do linger for a few years. But once you get past the 5-year period of time, I believe you can safely improve the grade for an individual who has discontinued their smoking. Now, that provides a little background on the staging and grading. Let's go into how you would gather information and then the cases to demonstrate examples of the different stages and grades. Now, it is necessary to do a comprehensive periodontal examination in which you do a full, complete examination, you obtain some findings. Now you can proceed to the diagnosis or the classification, and that will then drive your treatment plan and ultimately treatment for your patient. So parameters to gather, probing depths, the periodontal probe must be used to gather 6-point probing around each tooth. It's very important to note the gingival margin. Where is the gingival margin in relation to the CEJ? Because the combination of probing depth in relation to gingival margin allows you to calculate the clinical attachment level. And most of our computer programs will provide a calculation of the clinical attachment level. Check mobilities, because a grade or class 2 mobility or grade 2 or 3 is associated with the stage 3 periodontitis, and a furcation involvement of 2 or 3 is associated with the stage 3 or 4 periodontitis condition. So important to check mobility and furcations as part of your examination. So I want to emphasize the classification of periodontitis is not based upon the probing depth. The probing depth is not the determinant for the appropriate classification for the 2017 or the 1999 classification. The classification of periodontitis for both systems is based on the clinical attachment loss. How much loss of the attachment has occurred, and that then determines the appropriate classification to place your patient under. Just a real quick comment about the probing. As you probe, be sure interproximally to angle the probe into the caul area. If you don't angle it interproximally sufficiently, you may have, say, a 3 millimeter probing depth, when in reality it's closer to a 6 or 7 millimeter probing depth. So it's important to probe properly. And if you're at the junction, you always want to round up. So here, for example, you would round up. This definitely would be a 7. In this situation, I would even call it a 7. I mentioned the importance of evaluating where the gingival margin may be. This is an example of everything from a gingival recession to a gingival enlargement. Where you can see and feel the CEJ, it's relatively easy to determine that's 3 millimeters of recession. Now, on the other hand, if you have gingival enlargement, where the tissue has overgrown and the margin is coronal to the CEJ, you give your best estimation of where that CEJ may be. Sometimes you can feel the CEJ with a probe. Quite often you have to give your best estimation. The other challenge is if you've had a crown on a tooth or a restoration that has obliterated the CEJ, make your best estimation of where the original CEJ would have been. Now, mobility for our school, we have tried to keep it simple. Grade 1 mobility means there's up to 1 millimeter of movement in a horizontal direction. 2 would be up to 2. 3 would be more than 2, or depressibility. So taking the instrument handle, the ends of 2 instruments, pushing on the tooth in a horizontal direction determines mobility. And we always caution the students not to use the finger. Use 2 handles, because the cushioning of your fingertip may be enough to prevent you from seeing the actual mobility of a tooth. So schematically, what this represents is if you place your 2 ends of the mirror handle or probe handles here, and you push in a horizontal direction. If it's moving up to 1, it's 1 mobility, up to 2, 2. More than 2 becomes 3. Now, something that's very important, check for the vertical mobility, the depressibility in the socket. If you have depressibility as you push up and down vertically on a tooth, that's automatically a grade 3. And check furcations. We teach using the neighbor's probe to check the furcation involvements of teeth. And quick reminder, a grade 1 furcation is incipient, is just starting. You can actually see grade 1 furcations in stage 1 and stage 2 periodontitis patients. But once you get to grade 2 or 3, you're automatically into a stage 3 or 4 periodontitis condition. So a quick reminder, grade 2, we sometimes call a cul-de-sac. If you're driving in a neighborhood, you turn off into a cul-de-sac, you can go quite far into that neighborhood street, but you can't go completely through. And that's why I use the term cul-de-sac in relation to a grade 2, because the grade 3 furcation is through and through. You place your probe into the furcation on one side, you can physically see it. Or on a maxillary molar, if you place your probe here and you can feel the internal aspect of the opposing surface of the buccal surface of the palatal root, that would be considered grade 3. So think about the grade 1, 2, and 3 furcations in relation to the staging of periodontitis. So let's move forward. Let's use the case of a generalized stage 1 periodontitis as an example. And for a quick review, stage 1 is associated with 1 to 2 millimeters of attachment loss, interproximal attachment loss of 2 or more sites. You may be just starting to see radiographic bone loss, but in stage 1, you quite often may not see evidence of radiographic appearance, but you can certainly see deeper probing depths and attachment loss. If you do see radiographic bone loss, it's going to be mostly horizontal in nature. Stage 1s are very easy to miss if you're dependent solely on the radiograph, but if you're using your probe and you have your calculations for clinical attachment loss, you can then place your patient appropriately. With our students, they tend to focus in only on one parameter. For example, they see a 4 millimeter probing depth or a 5 millimeter or 6, but these are just some conditions to gather, but you have to put the whole picture into play in order to come up to the appropriate stage. So focusing in only on one of these may not allow you to recognize the worst case scenario to put the patient into an appropriate stage. So for generalized stage 1, grade B periodontitis, this is a slight periodontitis patient. This is case 1. And I fully recognize the loss of the incisal corner of number 8. That's probably what brought the patient into the office to begin with. The patient came to our school wanting to get that repaired, and upon periodontal examination, we certainly saw signs of inflammation. So from a periodontal perspective, let's talk about this 30-year-old male who smokes less than half a pack a day and has no diabetes. And if you look at the charting, these are probing depths, these are the clinical attachment levels, which our computers generate a calculation of the clinical attachment level. We suggest to our students deduct 1 to 2 millimeters, 1 to 2 off these numbers to account for the biologic width, which is now called supracrestal tissue attachment. Now you're getting into the 1s and 2s. And again, if you took only 1 here, you got 3, that correlates to stage 2. But I want to emphasize, look at the whole picture in order to come up to the appropriate stage. So as you look at the radiographs actually look pretty good. There might be a slight suggestion of 15% bone loss along the mandibular incisors. So that would be the radiographic appearance of beginning bone loss on the radiograph. So this patient that I just presented, why are they a stage 1 grade B? For stage 1, their attachment loss falls in the 1 to 2 millimeter category. The patient is just beginning to lose a little attachment. It's the so-called apical migration of the periodontal attachment. There's slight bone loss noted on the radiograph, 15%, and it's horizontal bone loss. And I want to caution that stage 1 periodontitis may not always be observed on the radiograph, and that's why it's so important to depend on your clinical parameters in stage 1. This patient smoked less than 10 cigarettes per day, and this is where the ratio came into play. I evaluated 10% bone loss in the worst area divided by his age is 0.33. So that ratio falls in that range of 0.25 to 1.0, and therefore becomes a grade B periodontitis patient. So looking at our table, the clinical parameter 1 to 2 millimeter loss, the very slight amount of bone loss noted on the radiograph can be observed on the table. And going to the grading table, the ratio fell here, and the patient smoked less than 10 cigarettes, hence grade B for this particular patient. Now let's move to a generalized stage 2 periodontitis type of condition. So stage 2 has a little more clinical attachment loss. Now we're seeing perhaps a little more bone loss, up to 1/3. Probing depths are typically around 5 millimeters, but I would caution against using the probing depth as the sole parameter to place the patient in the appropriate classification. And there's mostly horizontal bone loss in this individual. So here's the condition. You can see the very inflamed gingival tissues. You can see the calculus deposits here. You have probing depths. Yes, it's more than 5 that you see on the table. But if you look here at the attachment level, deduct the 1 or 2, you're right in that 3 to 4 millimeter attachment loss. I suspect that this reading was not at the CEJ as you evaluate the gingival margin. Measurement error probably came into play. I think it was probably 1 millimeter above the CEJ in all likelihood, which would put us right at 5 minus 1, 4 millimeter attachment loss. So if you look radiographically, even the moderate periodontitis patients may not show any radiographic evidence. As I looked really closely in areas, it was hard for me to say that we were looking at bone loss in up to 1/3. I think you could make a case for maybe 15% bone loss, but again, because there are likely crater defects along the molars, the crestal bone along the buccal and lingual surfaces do not allow the observation of the actual bone loss that's occurring interproximally. So this is a situation where we depend significantly upon the clinical findings. And those clinical findings were 3 to 4 millimeters of attachment loss. Many of the moderate periodontitis patients, you will see that radiographic bone loss beyond 15%, but not more than 1/3 of the root length, and mostly horizontal bone loss. And this patient, again, smoked less than cigarettes per day, and the ratio, percent bone loss, 20%. There was an area when I looked closely, we could say you could consider 20% divided by the age of 60.33 gets us to that ratio of B of being between 0.25 and 1.0. So looking at our table, we depended particularly upon the clinical parameter of 3 to 4 millimeters clinical attachment loss. In one area, I was able to find a region that would have suggested 20% bone loss, and the grade falls within the ratio of a grade B and smoking less than 10 cigarettes per day. So let's move forward into a stage 3 type of periodontitis, specifically a generalized stage 3 periodontitis patient. With stage 3, you're going to have even further attachment loss. The connective tissue attachment is migrating even more apically once you get to the severe periodontitis patient. Now it's usually quite easy to see the radiographic bone loss into the middle 1/3 of the root. With a stage 3 periodontitis patient, you can evaluate their medical history. You can ask them, how did you lose their teeth? And some may say, well, my teeth got really loose. It was uncomfortable to chew and eat on them, and they finally had to be taken out because they were so loose. That would be a history that might suggest a periodontitis cause for the loss of teeth, particularly a number of teeth. So if you've lost less than 4 teeth, 4 or less, then you're a stage 3. And we're again going back to the risk for periodontitis. If a patient is losing teeth due to periodontitis, they have greater potential to continue to lose teeth due to periodontitis and move into the stage 4. Here, probing depths around 6 millimeters. This definitely is when we're seeing changes in the radiographic appearance and the clinical loss of the bone. We have vertical defects as opposed to horizontal loss. This is where we're now thinking about class 2 or 3 furcations. You may actually have a class 1 furcation in the stage 1 or 2 periodontitis patients. But once you get in that stage 2 cul-de-sac or 3 through and through, move your patient into stage 3. And you may have some developing ridge defects, meaning the bone loss pattern of the remaining ridge is starting to change. That has implications particularly for implant considerations. So I go back to my radiograph. This would actually be a stage 3 periodontitis if the crestal bone loss was into this area, whereas a normal root length would still be probably a stage 2. Once you get into the beginning of the middle 1/3 of the root length, that's when you move your patient into a stage 3 periodontitis. So let's look at an example of a stage 3 grade C periodontitis. This is a patient who's a 48-year-old female. She doesn't smoke. she doesn't have diabetes. If you look at the condition on the distal number 28, that is an 8 millimeter probing depth, which is noted here, gingival margin at the CEJ. So we have an attachment level of 8 millimeters. So we're definitely beyond that 5 millimeters of clinical attachment loss. So this alone puts your patient into a stage 3. Now, if you look at the radiographs, this is the vertical defect of number 28 of more than 3 millimeters along the distal surface. So the vertical defect places this patient into stage 3 based upon this tooth. But if you look at the left side, now we're definitely observing the crustal bone into the middle 1/3 of the root. So this area, perhaps the grade 2 furcation here, places your patient in stage 3, in which we're now looking at the severe periodontitis type of patient. Again, even though the attachment levels may look reasonably okay along several teeth, the worst areas are now determining the stage for your patient. So why is this patient stage 3 grade C? The clinical parameters of more than 5 millimeters of attachment loss are present. We could see the radiographic bone loss into the middle 1/3, that vertical defect more than 3 millimeters along distal number 28. And you may be at potential for tooth loss. Number 28 with the deep vertical defect would be at risk for being lost. The number 19 with potential class 2 furcation is a tooth at greater risk for progression of periodontitis and ultimately loss of that tooth. Now, grade C, at worst, the patient had about 60% bone loss. She was 48. So that ratio becomes 1.25, which is definitely more than 1.0, and why the patient is now placed into grade C. So looking at our tables, the parameters of the 5 millimeters bone loss in the middle 1/3, the vertical bone loss noted on the radiograph, and the patient may be at risk for losing some teeth, but not the entire dentition. Grade C, this is the example of had a patient who didn't smoke, did not have a diagnosis of diabetes, and yet substantial periodontal destruction at a fairly early age. Early onset, rapid progression of attachment loss, definitely a ratio more than 1. So our patient is placed into a grade C, the highest risk for continuing periodontitis. Let's move to a generalized stage for periodontitis. This is, again, a severe periodontitis patient, sometimes called the terminal periodontitis, because of the potential to lose the dentition. So with a stage 4, again, it's a severe periodontitis patient. We're looking at similar parameters as 3, but this is a patient who might be losing a lot of teeth due to periodontitis, or there will be pending loss of teeth to place the patient into more than 5 teeth that will be lost and moves the patient into stage 4. We're looking at greater complexity now. This is a patient who is now having masticatory dysfunction, meaning they can't chew their food as well as they could before, possibly due to mobile teeth that are uncomfortable, possibly due to the number of teeth that are now missing, and there's not as much efficiency. This is a patient who you might see experiencing posterior bite collapse. The teeth are starting to drift and flare. The maxillary incisors moving is a common finding with this individual. You have less than 20 teeth and you have less than 10 opposing pairs of teeth. And these are key parameters to consider, because based solely on the clinical attachment loss and radiographic evidence, the remaining support may suggest a stage 1 or 2 periodontitis patient. However, the few number of teeth that remain, even with reasonably good remaining attachment, those few teeth are at much greater risk for continuation of periodontitis, because the few teeth are having to take the load that was meant to be distributed along the entire occlusion with an entire complement of teeth. So once you start losing teeth, much greater occlusal forces are being placed upon the remaining teeth, and therefore a greater risk for a loss of attachment over time. So again, difference between stage 3, severe periodontitis, you might lose a tooth. Stage 4, you may lose the entire dentition once it gets to this severity. So here's an example of a 50-year-old female. She's a non-smoker, but her HbA1c is 8.4. Certainly not a well-controlled diabetic patient. You can see the numerous missing teeth here. You can see on the photograph, the radiograph, definitely the numbers on your periodontal chart suggest attachment loss more than 5 millimeters. Radiographic evidence for sure beyond the junction of the coronal and middle 1/3. In fact, even approaching the middle 1/3. So radiographic evidence clearly points this patient toward a stage 4 periodontitis patient. Again, if you look at the radiographs, you can once again see the severity of the bone loss into the middle 1/3 and beyond. Plus, you can count the number of opposing pairs of teeth that come together. In this patient, 1, 2, 3, 4, 5. She has only 5 remaining opposing pairs of teeth. This is less than the 10 that places the patient into a stage 4. This is a very severe periodontitis patient who has a terminal dentition, loss of at least the maxillary dentition, and potentially the mandibular is imminent, and we move forward as no treatment would be indicated for this type of patient. So why is this stage 4 grade C? Clinically, there's more than 5 millimeters attachment loss, definitely bone loss into the 1/3 or beyond, less than 10 opposing pairs of teeth. This patient is going to lose her teeth. And the indirect method of percent bone loss divided by age, 75% bone loss divided by 50, 1.25. That's more than the 1.0 ratio. And in this patient, she is an uncontrolled diabetic. It's patient, more than 7. So that is why this patient falls into the stage and grade. So clinical parameters, radiographic parameters, number of teeth, unable to eat well with a few teeth that remain, and the ratio definitely over 1, and a patient who has a systemic risk with uncontrolled diabetes that allows the patient to lose their periodontal attachment much more into the future. So with that, I'd like to bring the presentation to an end. This was an introduction to the staging and grading of periodontitis with the new 2017 classification and how we related it to the prior 1999 classification, of which most of you are quite familiar, the generalized slight chronic periodontitis. Well, chronic periodontitis is no longer a term that we use, as we now call it a stage, and then we identify progression, those at great risk for rapid progression or at risk for future periodontal breakdown through the grading process. So I'd like to recognize the 3 stages of my career: my training in periodontics at the University of Nebraska, my clinical practice. I was in clinical practice for 30 years in my home state of Wyoming, in fact, my hometown of Rock Springs, Wyoming, so I'm still a Wyoming boy at heart. But I certainly am enjoying my new career as an educator at the University of Utah. Thank you very much for your time, and I appreciate the opportunity to present the information to all of you. Thank you very much.